This skills lab is about temperature management, and this is Susan Panter presenting for an NURS 2244. Homeostasis is a regulation of body temperature and is controlled by the hypothalamus, which is located in the brain. Our thermoreceptors are receptors in the brain that monitors the core temperature, and we also have thermoreceptors of the skin, which monitor external temperatures. So the two temperature variations we're going to talk about today are hypothermia and hyperthermia. First, let's talk about hypothermia, or low temperatures. Hypothermia is defined as core body temperature below 95 degrees Fahrenheit or 35 degrees Celsius. It is classified as mild, moderate, and severe, mild being temperatures of 90 to 95 degrees Fahrenheit, moderate 82.4 to 90 degrees Fahrenheit, and severe will be temperatures below 82.4 degrees Fahrenheit. Predisposing conditions that promote hypothermia include immersion in cold water, acute illness and post-surgery, traumatic injury, shock, immobilization, weather, whether it's to be cold, wet, windy, or chilly, advanced age, because we don't have as much fat stores to keep us warm, medications such as barbiturates and phenothiazines, alcohol intoxication and substance abuse, malnutrition, hypothyroidism, and inadequate shelter. Our signs and symptoms of hypothermia are also broken down into mild, moderate, and severe. We've all seen mild signs of hypothermia, such as shivering, dysarthria, or difficulty speaking words, poor muscle coordination, impaired cognition, and diuresis. Moderate would be weakness, increased loss of coordination, confusion, apathy, incoherence, stupor, and decreased clotting. And when we get into the severe signs of hypothermia, you'll start seeing vital sign changes such as bradycardia, hypotension, decreased respiratory rate, also dysrhythmias, decreased reflexes, decreased pain receptors, and acid-base imbalances will occur. Complications of hypothermia include clotting issues, fluid and electrolyte imbalances, and also acid-base imbalances, problems with acute respiratory distress syndrome, or ARDS, and pneumonia, renal failure, and then our life-threatening dysrhythmias and even death. So our life-threatening dysrhythmias such as AFib and asystole. Look at the first aid or pre-hospital care for hypothermia. First, we want to shelter from the cold. We want to remove any wet clothing. Also, we can utilize passive and active external warming, whether it would be apply clothing or blankets that are warm, warm packs, or convection heaters. We could also offer warm high carbohydrate liquids. We do want to make sure that we avoid alcohol or caffeine. And then the other thing we need to do is also monitor for the skin for burns. Nursing care for hypothermia include protecting from further heat loss, handling the patient with care to prevent ventricular fibrillation, place the patient in a supine position to prevent orthostatic changes, maintain ABCs, administer medications with caution. We have to think about our metabolism, which is unpredictable. Also, as the rewarming process occurs, drug toxicity could happen. Withholding IV drugs except vasopressin, and then also included in that would be defib once or until rewarming process is complete. So other things here that we have listed include applying heat blankets with caution. We want to avoid after drop or make sure that we are warming the trunk first. Administer warm IV fluids, administer heated oxygen, administer heated peritoneal, pleural, or gastric or bladder lavage, and then extracorporeal rewarming methods via cardiopulmonary bypass or hemodialysis for severe cases. Focused assessments are going to be really important. And so those patients receiving treatment for hypothermia, we want to monitor our airway, breathing, circulation, monitor level of consciousness, always check the skin and skin integrity, and then monitor our kidney function, making sure that we have adequate urine output, at least 30 milliliters per hour. So the story I want to share with you today is about my grandma Klaus. When she was still alive, she was around 76, 78 years old. She lived in a residential apartment for the elderly, and every day she would take walks. They had a little walking trail around the building, and so one evening she decided to take a stroll, and the one thing that she always did was push a shopping cart. They had some shopping carts downstairs, and so she pushed the shopping cart, kind of helped her keep her balance. Well, that evening she happened to be taking her walk, and she misstepped off of the walkway, and her shopping cart tumbled, and so did she. This happened to be a October night, and so our temperatures in October change quite a bit, and this happened to be one of our coolest nights in a long time. Well, because this happened in the evening and it was getting dark and dusk outside, nobody recognized that she had been outside. She had laid outside all night long until the next morning, when her neighbor was opening up her window and her curtains, and she looked outside and saw my grandma laying there. So she called 911. Well, the ambulance came to get her. When they found her, she was unresponsive and did not look well at all. In fact, we got a phone call from the doctor in the ER telling us to head over, that things didn't look well. Well, she happened to be hypothermic. Her core body temperature measured 76 degrees Fahrenheit. So, with what we've just been talking about, that would have fallen in the severe category of hypothermia. She was unresponsive. She was blue. She looked kind of waxy like. Of course, her heart, they were having to do all sorts of things to keep her heart out of abnormal rhythms. And the one thing the doctor said is, we're just going to try to warm her up slowly and see what happens, but it doesn't look good. Well, she happened to survive this, and I always say she is the lady with 9 lives. She lived into her 90s. I think she was 93 when she passed away from old age, but this was a scary situation for us and for her also. Now, when she was in the hospital, they had to do a lot of things like checking her skin integrity. I don't know how she didn't end up with any decubitus or frostbite areas, but she didn't. But she was the lady that survived this story. So I just kind of wanted to share that with you, so you kind of had some idea. And when she did fall, we were told that she was kind of curled up inside the shopping cart that she was pulling. Her clothing was partway off, and we think that was because she was trying her hardest, number one, to get up, but number two, then to stay warm inside that shopping cart. So just a story for you to remember hypothermia by. So you just heard the story about my grandma, and so now we might ask ourselves, why would we be doing therapeutic hypothermia? And yes, sometimes they do hypothermia as a therapy in order to help patients. And the patients that I'm thinking about happen to be patients that have cardiac arrest. They try to improve neurological outcomes after cardiac arrest by doing therapeutic hypothermia. So using hypothermia protocol, it is purposely lowering the core body temperature to 32 to 34 degrees Celsius or 89.6 to 93.2 degrees Fahrenheit for 12 to 14 hours. What this does is it decreases the metabolism, decreases the body's oxygen for demand, and also improves survival rate and neurological outcomes. In therapeutic hypothermia, there are 4 processes that they go through: a preparation, an induction, a maintenance, and then a rewarming phase. In the preparation phase, we have labs that are going to be drawn to monitor and have a baseline for our patient. Also chest x-rays. The other thing, they will have an art line in place and also monitor central venous pressure, also knowing the height and weight so that they can make sure that they utilize the correct temperature and correct medication amount. In the induction phase, they're going to apply the hypothermic device. One of them is called an Arctic Sun. They put the pads on. They'll infuse 2 liters of iced normal saline or lactated ringer for 15 minutes each. They also put ice packs in central areas. They will administer medications for sedation and then also administer medications to prevent shivering. So that would be like a neuromuscular blocking agent. They're going to monitor pupillary reaction every hour, making sure that they still have good pupillary response, and also report nystagmus to neurology. They will obtain an EEG and possibly consider continuous EEG monitoring. Under the maintenance phase, they're going to program the Arctic Sun temperature to 33 degrees Celsius or 91.4 Fahrenheit, documenting both water temperature and the client temperature hourly, monitoring blood pressure every 15 minutes until stable, and then hourly want to maintain systolic blood pressure greater than 90 millimeters of mercury and a mean arterial pressure of 75 millimeters of mercury. Also, vital signs will be supported with vasopressors to help keep them where they need to be. Monitoring central venous pressure and urinary UA or urine output hourly. The output greater than 200 or less than 30 times 2 consecutive hours needs to be reported. Also monitoring labs at various intervals, looking at basic metabolic panel, clotting times, and ABGs. Also monitoring blood sugars, because anything greater than 180, they're going to maintain that with insulin drips, IV. In the rewarming phase, they're going to use precaution with required potassium replacements. They're going to program the Arctic Sun 1 degree Celsius every 4 to 6 hours and discontinue it when the body temperature reaches 36 degrees or 96.8 degrees Fahrenheit. They're going to maintain sedation and paralytic agent until the body reaches the target temperature of 37 degrees Celsius and continue monitoring. Moving on to hyperthermia or high body temperatures. In hyperthermia, our temperatures are going to be above 101 degrees Fahrenheit or 38.3 degrees Celsius. They'll be associated with chills and malaise and are primary indicators of systemic infections. Temperatures greater than or equal to 104 degrees Fahrenheit or 40 degrees Celsius can be life-threatening. So what are the causes of hyperthermia? We all know that it is a normal immune response that the body has to help fight off infection and destroy pathogens. Also can be caused from other various reasons such as heat exposure or anesthesia. Signs and symptoms include a fever that is unresolved, skin that is hot to touch with a flushed face, chills, malaise, confusion, nausea, vomiting, rapid respirations, and tachypnea. Some of the complications of hyperthermia include dehydration, seizures, stress injury to the heart, and also we can have injury to the brain if the temperature is high enough and stays high enough for long periods. So we're going to treat hyperthermia with external cooling, such as tepid sponge bath, cool compresses, hypothermia blankets, and ice bags. One of the sources that I read did say that fans are discouraged due to airborne or droplet pathogen transmission. Another thing that they'll do is fluid administration, such as oral and IV fluids. Focused assessment for a client that has hyperthermia or that is receiving treatment will be watching for signs of dehydration, excessive thirst, poor skin turgor, dry oral membranes, acute confusion, and decreased urine output. Also, seizures, we need to be monitoring for that, and with high temperatures or somebody that has had known seizures, make sure they're on seizure precautions, and also shivering, because every time our patient shivers, that's just going to drive that temperature up higher. So we want to prevent that. So nursing care for a client receiving treatment to help battle hyperthermia, keeping skin and clothing dry, administer antipyretics such as acetaminophen and ibuprofen, administer fluids, whether it's oral or IV, monitor temperature frequently, and don't forget, assess, assess, assess. Let's talk just a little bit about malignant hyperthermia, also known as MH. Malignant hyperthermia is an inherited muscle disorder, acute life-threatening complication of certain medications used for general anesthesia. You'll notice all of these medications listed here end with ANE, and also succinylcholine is another medication. So those are the meds that we have a high risk for malignant hyperthermia. Reaction begins in the skeletal muscle that's exposed to the drug, and it causes increased calcium levels in the muscles and also increased muscle metabolism. Complications of malignant hyperthermia include hypercalcemia, hyperkalemia, acidosis, cardiac dysrhythmias, and high body temperatures. So when does malignant hyperthermia occur? Immediately after anesthesia induction, several hours after anesthesia administration, and after anesthesia has been terminated. So our patients that have undergone surgery and have had general anesthesia, we need to really make sure that we are monitoring them not only during but several hours after anesthesia has been terminated. Signs and symptoms. Let's talk about the early signs and symptoms first. Unexpected rise in the end tidal CO2, a decrease in O2 level, and tachycardia. Other signs and symptoms include dysrhythmias, muscle rigidity, especially the jaw and the upper chest. And we know that if our jaw has a rigidity to it, we can have problems with airway. Hypotension, skin mottling, cyanosis, myoglobinuria, and then a late sign is extremely elevated temperature of 111.2 degrees or 44 degrees Celsius. So now what? Survival depends on early diagnosis and immediate action of the surgical team. There's information in your Iggy book. It says that we need to stop all inhalation anesthetic agents and succinylcholine. ET tube needs to be placed if not already done. Ventilate with 100% oxygen. Administer dantrolene sodium or Dantrum and IV skeletal muscle relaxant. Administer IV fluids. Apply a cooling blanket. Treat any dysrhythmias, and again, continue assessing your patient. So there is some teaching that goes along with malignant hyperthermia, and that is for testing for those patients that might be at risk. We also want to make sure we're reporting a history to the PCP, the surgeon, or the anesthesia and the anesthesiology actually. And this can be treated with dantrolene before, during, and after surgery to help prevent problems. So last, we need to make sure we're doing good documentation, utilizing our SBAR, giving good handoff and good report to our oncoming shift or our new department. Make sure we're documenting any signs and symptoms we see, medications that we have administered, and then also treatment that we have done, such as if we're doing cooling blankets or doing a tepid sponge bath. Make sure that we are talking about the duration and how long we've done the therapy for, exactly what we've done, and where our temperature was before and where our temperature ended up at the end. And that is temperature management in a nutshell. Thanks for being patient today. Sorry our day was so busy and crazy, but hope everybody has a good evening, and we'll see you tomorrow.